about diabetic ketoacidosis, one of the life-threatening complications of diabetes. So firstly, I will be explaining the pathophysiology, the biochemical abnormalities, the signs and symptoms, and the management of diabetic ketoacidosis. The figure drawn here shows the pathophysiology of diabetic ketoacidosis. It occurs because of absolute or relative insulin deficiency, and because of insulin deficiency there is decreased glucose uptake by the tissues and the organs, and this results in build-up of glucose in the circulation. The insulin deficiency is also accompanied by a rise in counter-regulatory hormones such as glucagon, cortisol, growth hormone, epinephrine, and these hormones are responsible for increase in the glucose output by the liver by the process of gluconeogenesis, that is the process of synthesis of glucose from amino acids, and also increase in glycogenolysis, that is breakdown of glycogen to glucose. So rise in the circulating levels of glucose because of the process of gluconeogenesis, glycogenolysis, and together this results in hyperglycemia, rise in the blood glucose levels. Secondly, because of insulin deficiency, there is increased catabolism of proteins leading to proteolysis and decreased protein synthesis. So proteolysis or decreased protein synthesis releases amino acids into the circulation, and these amino acids are used as substrate for the synthesis of gluconeogenesis and the synthesis of glucose. So thirdly, because of insulin deficiency, there is impaired carbohydrate utilization. This in turn increases the fat metabolism or increased lipolysis. So there is increased lipolysis leading to excess free fatty acid formation in the circulation by the process of beta oxidation. So beta oxidation of free fatty acids leads to the formation of ketone bodies in the circulation, and the process of formation of ketone bodies is known as ketogenesis. The ketone bodies that are formed in the circulation are acetone, acetoacetate, and beta hydroxybutyrate, and the process of formation of ketone bodies is known as ketogenesis. So as the ketone body formation increases, there is progressive rise in the blood concentration of ketone bodies, and this is known as ketonemia. And since these ketone bodies are acidic organic substances, they are acidic in nature, the body has a buffer system to neutralize these ketone bodies. So in the early stages, the cellular and extracellular buffers neutralize these ketone bodies that are acidic in nature, and this is reflected by a normal arterial pH and mild base deficit. If the situation is untreated and the ketone body concentration continues to rise, it exceeds the body's capacity to extract them. So these ketone bodies overflow in urine, and this situation is known as ketonuria, that is excretion of ketone bodies in urine. Thus, increased fat metabolism or lipolysis increases the fatty acid formation. The beta oxidation of fatty acids leads to the formation of ketone bodies, that is ketogenesis, and excessive formation of ketone bodies is known as ketonemia, and ketonemia leads to ketonuria, that is release of ketone bodies in urine. So if these primary metabolic derangements are not corrected, it leads to secondary derangements, and excessive formation of ketone bodies finally leads to ketoacidosis, a state of clinical metabolic acidosis. Because the ketone bodies are acidic in nature, these are acidic organic substances, and these in turn lead to clinical metabolic acidosis. Now, in response to metabolic acidosis, there is respiratory compensation, and this manifests as Kussmaul's breathing. So what is Kussmaul's breathing? In the initial stages, the respiration is rapid and shallow, but as the metabolic acidosis becomes more severe, the respiration becomes more deep, slow, and labored, and this type of respiration is known as Kussmaul's breathing. So this type of breathing is a characteristic feature of severe form of diabetic ketoacidosis. Now the second part of diabetic ketoacidosis is hyperglycemia, which occurs because of insulin deficiency and rise in counter-regulatory hormones such as glucagon, cortisol, epinephrine, growth hormone. Also, severe hyperglycemia exceeds the renal threshold for glucose absorption, and this causes increased loss of glucose in urine. So increased loss of glucose in urine, and this causes osmotic diuresis. The result of osmotic diuresis is water loss and electrolyte disturbances. So there is loss of glucose. Along with loss of glucose, there is loss of electrolytes such as sodium, potassium, calcium, magnesium, phosphate in urine. So these are some of the electrolyte disturbances that occur in diabetic ketoacidosis, which occurs as a result of osmotic diuresis because of rise in blood glucose level, because of severe hyperglycemia, loss of glucose in urine causing glucosuria. So there is marked hyperglycemia, and this raises the serum osmolarity. So rise in serum osmolarity is seen in diabetic ketoacidosis. So speaking more about electrolyte disturbances, the most characteristic electrolyte disturbance is hypokalemia and hyponatremia. So how does hypokalemia occur? Now because of ketoacidosis, there is metabolic acidosis and there is accumulation of H plus ions in the extracellular compartment. And these H plus ions are exchanged for potassium ions. So potassium moves out from the cells into the extracellular compartment, and it is lost in urine because of osmotic diuresis. So there is loss of potassium in urine because of osmotic diuresis, leading to hypokalemia. Also there is hyponatremia. This is because of increased serum osmolarity, and increased osmolarity drives water from the cells into the extracellular compartment, diluting the sodium ions, leading to dilutional hyponatremia. So there is water loss. Along with water loss, there is loss of sodium, loss of potassium in urine, leading to hypokalemia, hyponatremia as electrolyte disturbances. Diabetic ketoacidosis is characterized by hyperglycemia, ketoacidosis and ketonuria. Biochemically, there is rise in the serum concentration of ketones greater than 5 milliequivalent per liter. The blood glucose concentration markedly increases, which is greater than 250 milligram per deciliter. Also because of metabolic acidosis, there is decrease in the bicarbonate levels and the arterial pH decreases. The bicarbonate levels are less than 18 milliequivalent per liter and the arterial pH drops to less than 7.3. There is rise in serum osmolarity, and because of the dehydration, because of the water loss, there is tissue hypoperfusion, and this can cause renal dysfunction, leading to rise in the serum creatinine level, serum uric acid level. So these are some of the biochemical characteristics of diabetic ketoacidosis. Now coming to the causes of diabetic ketoacidosis, which mainly occurs in type 1 diabetes mellitus but can also occur in type 2 diabetes. In 25% of the patients, diabetic ketoacidosis is present at the time of diagnosis of type 1 diabetes, and this occurs because of acute insulin deficiency. It can also occur because of poor compliance with insulin therapy or omission or missed insulin doses because of profound illness, certain infections such as bacterial infections, UTI, pneumonia, myocardial infarction, or stress such as medical, surgical or emotional stress can lead to insulin deficiency and predispose to diabetic ketoacidosis. In type 2 diabetes mellitus, intercurrent illnesses such as bacterial infections, UTI, pneumonia are the common causes, and also some of the patients with type 2 diabetes mellitus treated with SGLT2 inhibitors are reported with diabetic ketoacidosis. So let us now discuss the signs and symptoms of diabetic ketoacidosis, and this we can relate with the pathophysiology which has been described earlier. So in the early stages, because of hyperglycemia, there is polyuria, polydipsia. GI symptoms can be seen because of the formation of ketone bodies and nausea, vomiting, anorexia, decreased appetite can be seen. Because of loss of water, there is dehydration and there is dryness of the skin, mucous membrane, decreased perspiration. Volume loss can lead to hypotension and tachycardia. Also because of metabolic acidosis and respiratory compensation, there is tachypnea. Or if there are signs of intercurrent illness such as urinary tract infection, respiratory tract infection, then signs and symptoms such as fever, chill, chest pain, dyspnea can be observed. Lastly, let's discuss the management goal and the medications that are used for the treatment of diabetic ketoacidosis. So the treatment of diabetic ketoacidosis should aim at 1. Fluid resuscitation, 2. Reversal of acidosis and ketosis, 3. Normalization of blood glucose levels, 4. Replenishment of electrolytes and volume losses, and 5th, identification of underlying cause such as infections that predisposes to diabetic ketoacidosis. The medications that are used for the treatment of diabetic ketoacidosis are, so for the treatment of diabetic ketoacidosis, insulin therapy is used, and insulin is administered intravenously because it is an emergency condition. The insulins that are used for the treatment of diabetic ketoacidosis are rapid-acting insulin analogs and short-acting insulins. The rapid-acting insulin analogs are insulin lispro, aspart, glulicin, and short-acting insulin is regular insulin. Secondly, for fluid replenishment, potassium supplements such as KCl or potassium chloride is used. To reverse metabolic acidosis, alkalinizing agents such as sodium bicarbonate is used. Lastly, the underlying infection that predisposes to diabetic ketoacidosis should be treated.